Thank you very much for joining this talk on eating disorder symptoms in adolescence and the potential role of decision making. This research has been conducted alongside my collaborators, Professor Irini Fleury and Dr. Marta Francesconi. I'm going to share with you what I think some of the unanswered questions are in our field around decision making and talk you through how we've tackled these in our research. I'll share with you our findings and what we think these findings might mean. So first of all, what is decision making? Decision making is an executive function skill. It involves selecting adaptive or advantageous behaviours or thoughts. It's a skill that's supported by the ventral medial prefrontal cortex and the ventral striatum. Effective decision making appears to follow a J-shaped developmental trajectory. This means that it declines from late childhood into early adolescence, and then shows an improvement in mid-adolescence and into early adulthood. And we know that other disorders, like eating disorders that originate in adolescence, such as conduct disorder, also patients with these conditions show disadvantageous responding when they're asked to complete tasks where they need to make decisions under conditions of risk. Patients with eating disorders tell us that decision making is a real trouble for them. Some of them, when faced with having to make a decision, will over-control their behaviours as a way of managing it, and others will lose control of their behaviour. We also know from systematic reviews that people with eating disorder, all types of eating disorder pathology, have significant loss aversion. Restrictive eating behaviours are associated with overly cautious responding, whereas binging appears to be associated with more reward-driven responses. Contemporary models of eating disorders suggest that differences in appetitive motivation may be one of the factors that maintain the illness. And thinking more broadly, there is the suggestion that across psychiatric disorders, decision-making differences might underpin psychiatric conditions. What we've learned so far in our research is that higher risk-taking and poorer quality of decision-making measured at age 11 in a gambling test appear to be associated with the later presence of eating disorder symptoms measured in adolescence at age 14. However, what we don't know is whether developmental changes in decision-making are different in those who then go on to later develop eating disorder symptoms relative to asymptomatic peers. We're tackling this question using the Millennium Cohort Study. This is the fourth longitudinal birth cohort study to be conducted in the UK. It consists of nearly 19,000 children who were born around the year 2000, and they've been followed up over 7 different assessment periods to date. The sample is stratified to include all 4 countries in the UK and overrepresents minority groups to manage attrition. We've been using data from Sweep 5 when we first have information about the Cambridge gambling task, when the children were aged 11. And we've also been using data from Sweep 6 when the children were aged 14 and when eating disorder symptoms were first asked about. This gives us a final sample of 11,303 boys and girls. In our study, decision-making under conditions of risk is measured using the Cambridge gambling task. This is a task from the Cambridge Neuropsychological Test Battery and is designed to assess decision-making under conditions of risk outside of a learning context. The Cambridge gambling task offers a number of outcome variables. These include risk-taking, quality of decision-making, deliberation time, risk adjustment, and delay aversion. The eating disorder symptoms that have been asked about in the Millennium Cohort Study at age 14 include a measure of body dissatisfaction, operationalised as participants reporting that they perceive themselves to be too overweight. Questions around the intention to lose weight and actual behaviours designed to influence weight and shape that we've operationalised as dietary restriction. We also have measures of participants' weight, and we've been able to understand, based on the UK90, the number of people that might be falling into the overweight or underweight categories. And finally, we have a subjective measure of excessive exercise, which is the use of driven exercise to influence body weight or shape. In our models, we've controlled for a number of confounders also measured in the Millennium Cohort study, associated with exposure and outcome. Our findings are derived for this study are derived from 3 analytic tools. The first is latent class analysis, and this has allowed us to identify different symptom groups. We've then calculated change in the Cambridge Gambling Test outcome variables between the 2 measurement time points at age 11 and age 14. And we've developed regression models which allow us to predict symptom group membership based on observed change in the Cambridge Gambling Test variables. The latent class analysis, the best solution for the data, yielded a 2-group solution. We've called these the low symptom and high symptom group. Those in the low symptom group did not perceive themselves to be too overweight. They were not intending to try to lose weight or actively restricting their nutritional intake or using exercise to influence shape and weight. Finally, they were likely to have a weight that was not in the UK90 over or underweight ranges. Conversely, the high symptom group perceived themselves to be too overweight. They were intending to try to lose weight, and they were actively restricting their nutritional intake and using driven exercise to influence their weight. Finally, this group were likely to have average or above average weight according to the UK90. Supporting our previous work, risk-taking and quality of decision-making measured at age 11 predicted membership of the high symptom group at age 14. These are the rows in green. This suggests that higher risk-taking and more suboptimal quality of decision-making at age 11 predict the later presence of eating disorder symptoms when participants were measured again at age 14. All participants showed a change in their risk-taking scores between the ages of 11 and 14, with scores lowering over time, in line with that J-shaped developmental trajectory. However, the high symptom group changed less than the low symptom group. This suggests that the high symptom group appear to follow a different developmental trajectory in terms of their risk-taking skills, the specific component of decision-making, from age 11 to age 14. Indeed, they don't change their performance over time when we would expect them to. This suggests that those who begin to develop eating disorder symptoms in adolescence are showing less adaptive responding on this particular task. The take-home message of these findings is that risk-taking changes less in those with eating disorder symptoms between the ages of 11 and 14 compared with low symptom peers. This may be evidence for a developmental etiology for eating disorders. And one implication of this work might be that if we can help young people to make more adaptive responses in tasks and activities where they have to make decisions under conditions of risk, perhaps this could be one way that we could steer them away from eating disorder symptoms early on. In future work, we'll explore how responses on the Cambridge Gambling Test at ages 11 and 14 influence the later presence of eating disorder symptoms at age 17. This will allow us to further examine the developmental trajectory of decision-making in eating disorders. Thank you very much, and I look forward to engaging with you around this research in the questions and answers.